Welcome, and thank you for joining us today. My name is Stephanie Paul, and I am the Executive Director of MyFace. I am pleased to welcome you to this web education program designed for families of children with craniofacial differences, caregivers, and healthcare providers. I would like to thank the Milbank Foundation for funding this important program and acknowledge their appreciation for the critical need to provide educational programs like this one for families of children impacted by craniofacial differences. MyFace advocates for a holistic, comprehensive team approach to care through the wide range of programs we fund, including support of the world-renowned MyFace Center for Craniofacial Care at NYU Langone Health in New York City, which serves as the gold standard for craniofacial care. In addition, MyFace provides important direct services such as access to individual and family support groups, topic-driven workshops, informational webinars, and networking opportunities. We also provide travel assistance and housing for out-of-town families, as well as providing access to educational resources and raising public awareness. MyFace is here to bring together the craniofacial community and help transform the lives of children and adults living with craniofacial differences. We believe that everyone deserves the chance to thrive and have the best life possible. And now to our program. Our presenter today is Dr. Thomas A. Imahiyerobo, Assistant Professor of Plastic Surgery at Columbia University Medical Center and Director, Cleft and Crainofacial Surgery at Morgan Stanley Children's Hospital in New York. We will then hear from a family who will share their experience with the prenatal diagnostic process. After the presentation, we will open the program for questions from participants. As you think of questions for our speakers, please enter those questions in the Q&A box during the program. We encourage everyone to complete the evaluation after the program because your feedback is instrumental in helping us plan for future educational offerings, including webinars like this and other programs. You may view the materials for this program and a printable version of today's slides by clicking on the links below the presentation window. It is now my pleasure to introduce Dr. Thomas Mahiarabo.
Thank you, Stephanie, so much for this introduction, and good evening to all of our participants. It really is a privilege for me to be here with you tonight, speaking about a subject which is not only a large part of my practice, but also one that I feel very passionate about. And it's been a privilege to begin a partnership with organizations like MyFace that are focused on cleft advocacy and cleft care. My name is Thomas Mahiarabo, and I am a director of craniofacial and plastic surgery at Columbia Presbyterian Hospital in New York. And tonight we'll be talking to you about prenatal diagnostics for cleft lip and palate and the impact on postnatal care. Our goals for the presentation tonight are going to be as follows. We're going to begin by reviewing some background information related to cleft lip and palate. And then we'll really spend the meat of the conversation discussing my approach to prenatal diagnosis. I want to review key concepts for prenatal counseling for the benefit of both those receiving and giving the counseling, and then really want to also emphasize the impact that good counseling can have on postnatal care. And then at the tail end of the talk, we will introduce some concepts on important aspects of community building around the cleft lip and palate diagnosis. It's sort of a broad focus for the talk, and so we're going to jump right in. Let's begin with some background information and discussing the scope of what we're talking about. As many of you know, cleft lip and palate is one of the most common craniofacial differences that a child can be born with, affecting as many as 1 in 700 live births. There are many different types of clefts, and clefts come in many different forms. The most common ones that we see in a practice like mine would be cleft lip, cleft palate, or a child that has both a cleft lip and palate. One key aspect to understand is that the majority of children who are born with a cleft are going to have an isolated cleft. This means the child is going to be totally healthy and have no other malformations outside of the cleft itself. However, a subset of children, somewhere around 30%, will be born with additional congenital anomalies. And in addition, a subset of those children will actually have a craniofacial syndrome that is one that is defined by a genetic malformation. And so you can imagine that there are definitely considerations that are going to be different based off of whether a child has an isolated cleft versus a cleft with additional anomalies versus a craniofacial syndrome. However, the vast majority of the counseling is actually going to be the same. And so I want to give a bit of a roadmap for going through the process of counseling a child, no matter what type of cleft they have. When a family receives a diagnosis of clefts, there are some questions that come up that are universal. For instance, how did this happen and when did this happen? If we tackle the first question, we have to admit that the answer is at this time inconclusive. We don't actually know how most clefts occur. The thought currently is that usually this is a multifactorial process where a combination of genetic factors, epigenetic factors, and environmental factors can contribute to the formation of a cleft. When we go through our genetic workup, more often than not, the answer is going to be inconclusive, and the thought is the cleft is going to be sporadic. And so right off the bat, that's a challenge for parents because we don't have an answer for how this occurred. The second question on when this occurs is much more straightforward. We know that the normal formation of the lip is happening during 4th to 5th week of gestation, and a failure of fusion of the frontal facial processes during that time will lead to the formation of a paramedian cleft, otherwise known as a cleft lip. And similarly, during the 6th to 8th week of gestation, failure of fusion of the maxillary processes will lead to a cleft palate. So what does this tell us? This tells us that a cleft is forming quite often before some families might even know that they're carrying a child, and certainly before a significant amount of diagnostics is done. Over the last 30 years, there's been a lot of advances in prenatal diagnosis and the use of prenatal imaging to diagnose congenital malformations. Because the lip and the palate clefts are forming early in gestation, this gives us an opportunity to diagnose this relatively early in the pregnancy. Most diagnoses are going to be made during the anatomy scan between week 16 and 22 of gestation. And families can take heart in the fact that more than 90% of clefts can be detected prenatally. Now, there's a range, anywhere from as little as 30% up to as much as 95% of the time we can see a cleft. And the range depends on things such as the child's anatomy, what imaging modality is being used, and the expertise that a given center has with diagnosing prenatally. So as part of this discussion, I'm going to give some tips on how we can ensure that the diagnosis is made whenever it is possible. We also have to make a distinction between diagnosis of the lip and the diagnosis of a potential cleft palate, because we know that it's much easier to see a cleft lip on an ultrasound than it is to see a cleft palate. But families really want to know the answer to both these questions before their baby comes. And so again, we're going to discuss both of those things. Once a diagnosis is made, again, there are many questions that come up that I think are very much universal. And when we've talked to different families, we hear the same things. These are questions like, what do I do next? What will my child look like? How is my child going to eat? How is my child going to speak? And what surgeries will my child need? Now, as soon as a diagnosis is made, the clock is ticking for us as healthcare providers to begin answering these important questions for families. And this is an opportunity for us to provide critical information. However, this early period soon after diagnosis is also a time where parents can get some misinformation. Studies such as this one, which comes out of Sweden, noted that parents are most often going to get the information that they hear first about their cleft from a medical provider, such as a craniofacial specialist or a maternal fetal medicine specialist who is a high-risk OB. However, that information is not always accurate. And as much as 25% of the times, families feel that the information they initially get is not accurate. So we want to really focus in on the prenatal counseling and optimizing it. Why is that important? Because early misinformation can contribute to negative feelings about the pregnancy and about the prospects or the prognosis for a child. And we really want to avoid any of that misinformation impacting a family's decision on their pregnancy. So the rest of this talk, what I'm going to do is really give you an outline or a roadmap for how to go through the process of prenatal counseling, trying to highlight the key factors which should be done during the prenatal period to ensure that we have a good beginning to our cleft journey. This may be one of the most important slides in the discussion. What this is, in my mind, is how do we do a comprehensive cleft diagnostic workup? And what answers do we want to have at the end of our diagnostic workup? If we start at the top, we see that first, a cleft is seen most likely on an ultrasound during an anatomy scan. From there, we want to try to categorize the child in one of two groups. Is this a child who's going to have an isolated cleft lip and or palate and nothing else going on? Or is this a child that has additional congenital malformations? If we look at the isolated cleft group, we want to further categorize whether or not we're dealing with a lip-only cleft or a lip and palate. If we look on the other side with children that will have additional malformations, we want to, if we can, answer the question whether or not this is a syndromic presentation with an underlying genetic anomaly versus whether or not this is a non-syndromic presentation where a child just has multiple congenital malformations. So there are key steps that go into us figuring all of this out for a family. The first thing starts with prenatal imaging. There are different types of imaging. The gold standard in most institutions is going to be 2D and 3D ultrasound. However, in our institution, we often add in fetal MRI, and I'll discuss why that is. After the imaging has been done, the additional steps that need to be taken for a comprehensive workup include genetic testing and counseling, a fetal echocardiogram, and a consult with maternal fetal medicine. Let's focus in on fetal MRI. We've said already that most clefts can be picked up on fetal ultrasound. What does MRI add to that discussion? This is a paper that I published in the Annals of Plastic Surgery years back, where we looked at the use of fetal MRI for the diagnosis of cleft palate. And essentially what we found is that fetal MRI gives us the best chance to diagnose the presence of a hard and or soft palatal cleft in utero. Not only does fetal MRI pick up most of the palatal clefts, it has significant accuracy when done with someone who's commonly familiar with the technique, where almost 100% of the time, if it looks like there is a palatal cleft on the MRI, a child will have a palatal cleft at birth. At our institution, we follow what is called an integrative model. We don't just send parents to multiple different places and multiple different appointments to get this comprehensive diagnostic workup done. We partner with our maternal fetal medicine group within an organization called the Center for Prenatal Pediatrics at Columbia Presbyterian. And parents are able to go to the Center for Prenatal Pediatrics and get the totality of their comprehensive workup done there, and often get it all done in one day. Now, a family might look at this and say, that's a lot to do in one day. We're talking about imaging, potential genetic testing and counseling, echocardiogram, meeting with maternal fetal medicine. But the benefit of doing all of this comprehensive workup is at the end, I can tell a parent with some confidence whether or not they have a child that is going to have an isolated cleft lip or a cleft lip and palate and be otherwise healthy, or are we following in a box that's going to be a little bit more complex? And that's really important information for their planning and for the counseling. There's certainly been a number of reports, including this one by one of my colleagues, Albert O. at Children's National in Washington, D.C., which indicates that there are many benefits for doing this inside an integrative model, where everything is done at one place and often at one time. And for instance, using this integrative model, such as what we do at Columbia, leads to children being taken care of by a craniofacial specialist much quicker after they're born than if parents have to worry about running around to different places to get the information they need. Let's move on and focus in specifically on counseling. So we've done our imaging, we've done our workup. We now have an idea what the anatomy is that we're expecting when baby's here. What are the next steps that we need to do to get a family prepared for the birth of the child? That begins with a comprehensive counseling session with a craniofacial specialist, such as myself. At these comprehensive counseling sessions, what I try to do is to begin by giving a parent an understanding of the fact that when we're taking care of a child that has a cleft lip or palate, this is not a one and done episode. There are different things that need to happen at different times along the child's lifespan. And I try to introduce the family to the concept that we are about to embark on a cleft journey. We're doing this together. I'm helping to lead the family through the journey. And giving family things like this, which is a cleft timeline, helps them to understand the different mile markers at the journey and different areas where interventions might need to take place. Families are always keyed in on this second circle, which is when the cleft lip is going to be repaired. But I try to focus a lot of the time on this first circle, which are all the important things that actually need to happen before surgery is ever done. During the comprehensive counseling session, we also spend a lot of time talking about coordinated craniofacial care. At the Columbia Presbyterian Hospital, we have a cleft and craniofacial center and a cleft and craniofacial multidisciplinary team. I'm not going to go in detail into all of the benefits of coordinated cleft care, because that is a subject of a prior webinar that was done on the MyFace platform that I would refer you to because it is excellent. But I will mention that there is a bulk worth of data that shows that children are ideally taken care of within the concepts of a multidisciplinary cleft and craniofacial team. And a counseling session should introduce you to a team that is available to you and should walk you through the benefits of team care and the many different components and many different players who should be on an adequate team. Once we've talked about comprehensive cleft care, I then like to move into discussion of potential cleft challenges, because I want parents to be ready for what is going to happen once baby gets there. And part of being ready is knowing what are the potential challenges that can happen. Many of these things are things that are going to happen before any surgery occurs. And in fact, overcoming these challenges is an important step in getting baby ready for surgery. So I will discuss with families the issues surrounding feeding and weight gain for a child that has a cleft. And we review data that shows that children that have a cleft, whether that's a cleft lip alone or a cleft lip and a palate, in general have further challenges with gaining weight versus children who do not. But as we're talking about these challenges, we also want to talk about potential solutions. So some institutions will use feeding tubes as a way of treating children that have cleft lip and palate before surgery and ensuring adequate weight gain. But in my opinion, there are better ways and better resources. And we try very hard to avoid feeding tubes in my patients. And so what we'll talk about instead are the utilization of specialized cleft bottles. There are many different bottles that can be used to feed a child that has a cleft lip and palate. I don't advocate for my parents necessarily to go out and get many different types. I have found in my practice that the average child does well with this particular type, the Dr. Brown specialty feeder. And in our institution with our integrative model, we provide an initial kit that includes a specialty feeder for our patients. But just giving parents the information that they may need a specialized bottle, that it may be prudent to go ahead and get one to start them off on their journey is an important concept. We talk about weight gain, And I tell parents, I cannot do any good surgery without good weight gain. And we talk about our monitored feeding program, which is a partnership between ourselves, a child's pediatrician, and our feeding specialist, where we can, in a very detailed way, monitor a child's weight gain and potentially intervene if necessary if we're not happy with how that's going. We talk about other challenges such as significant reflux disease, which can be seen in the cleft population. This is another paper that I published in the Journal of Crainofacial Surgery, where we talk about the challenges such as reflux and the potential need for treatment. And this is an area where both parents and providers need to be educated. And we review a litany of other potential cleft challenges. We talk about the potential need for revision surgery when a child is older. We talk about residual cleft nasal anatomy that may need to be addressed. But we pair these discussions of challenges with potential solutions. And we talk about things such as pre-surgical nasal molding and pre-surgical orthopedics as a way of minimizing the need for future interventions and actually maximizing the results from the initial cleft surgery. I show parents images of my actual patients who have gone through these steps, because I think it's important for parents to know during the counseling sessions that they are going to be able to do this journey and that there are others who have done this journey before them and who in fact will be there to help them through their journey. We review the data on the efficacy of things like pre-surgical nasal molding and reducing the need for future revision surgeries, because I want a parent to know why I'm going to be asking them to put their baby through this process. We talk about multiple different options for pre-surgical nasal molding. Our institution is not wedded to one approach. We use both nasal alveolar molding as well as other techniques, and parents should know about the different options. And then we move on to a process of what I call demystifying the cleft. And then I think it's very critical and important for parents to understand the wide possibilities for what clefts can look like, but not only understanding what clefts can look like, but also what they can look like before and after reparative surgery. I think going through this process of demystifying the cleft is important for getting a parent and a couple ready to accept their baby when their baby is born, because they can see that many other babies have had surgery with very robust results, and that there's going to be a time where they look at their baby and they don't see the cleft anymore, they simply see their child. So I go through examples of the full range of clefting, from very small microform unilateral clefts, such as what this young lady has, to slightly more involved incomplete clefts, to incomplete clefts with Simon-Art's band and significant nasal involvement, to incomplete clefts with complete nasal collapse, to complete clefts that have loss of nasal floor and wide cleft diameter. And what families see as they go through these litany of different examples is that no matter what we're presented with, we can do a good job with surgery and repair. We go through similar examples for bilateral clefts. We look at bilateral microforms. We look at bilateral incompletes. We look at situations where we may have an incomplete and a complete on one side. We look at bilateral completes that may be wide and may benefit from something like NAM. And we look at bilateral completes on both sides, where you really are going to have a relatively wide cleft to repair. And again, the consistent theme that I'm trying to give parents is knowledge and hope and reassurance that we do have good answers for their child, and that there is going to be a way for us to begin to help them move past the cleft diagnosis. Before I talk about building a cleft community, which is actually an aspect of the counseling that I have found increasingly important as I've gone through my career, I want to highlight why any and all of this is important. And there's actual data that shows that good prenatal counseling has benefits, both functional and emotional, for parents and children after birth. And this is what I call the impact on postnatal care. And so there are good data to show that adequate prenatal counseling, where the concepts of feeding challenges have been introduced, will minimize the likelihood that a child is going to need admission to the NICU and minimize the likelihood that a child is going to need a feeding tube, because parents are prepared for the challenges that they're going to have to face. There is good data to show that mothers who have had complete and appropriate prenatal counseling sessions are going to have lower rates of postpartum depression when their child is born. And there is good data to show, such as this study from some of our colleagues in France, that children that have had adequate counseling are going to be introduced to a comprehensive Cleft team earlier and receive adequate care earlier, and therefore receive surgery earlier. And so what I try to underscore for my patients and my colleagues who are doing counseling is that it behooves us to do a good job at this, because it has such an impact on the beginning of our lifelong Cleft journey. And as with any other journey, we think that a good start is going to lead to a good ending. And one of the things I underscore for colleagues who are beginning prenatal counseling is that you may not be able to accomplish and cover all of these things in a single counseling session. And I often have parents come back for a later third trimester counseling session so that we can review these concepts again and we can hone in on the birth plan, and we know the plan for postnatal follow-up. And I think that really gives parents confidence in the fact that their journey is going to begin on the right foot. So as I'm finishing up, I want to introduce one last concept, which is building a Cleft support system. And again, I want to comment that I think that this is as equally as important as any of the medical information that I share with my patients. And why is that? It's because we know that receiving a diagnosis of a child who's going to have a cleft lip and or palate, no matter what associations there are with it, is one that is a significant diagnosis for a couple and a family to receive. And it does have an emotional impact on them. And so I want parents to know that they're not facing these challenges alone, that there are resources out there that they can call upon to help them in their journey. I introduced parents to materials from some of our national partners, such as the American Cleft Palate Crainofacial Association, the Children's Crainofacial Association, and of course, MyFace. Part of what we want to do during the counseling session is connect our families with other families who have gone through this journey before and are further along in their journey. We may think of this as paying forward, but I really think of this as building our Cleft community. At Columbia, we have certain activities that we do where we get all of our families together. These are images from our Cleft Lip and Palate Team Day, which is a day that we do annually where children who we've treated with a diagnosis of cleft lip and or cleft palate are invited back to the institution for a celebration with their families and with other children that share diagnoses like these. We do a lot of work in trying to connect our families locally with other families who are going through the diagnosis or have recently gone through a diagnosis like they have. And we take many, many steps to help build our Cleft community, because we find that when we connect people, they have a lot of commonality in their experience, and they can help each other as much as I can through their journey. My last comment is that MyFace, I feel, is uniquely situated to help us in building these Cleft support teams by providing national and international resources for families and children going through their journey. And I really believe that once a child gets off to a good step in their journey, it idealizes the journey from there. We're going to have an opportunity now to hear from one of the families that I've had the privilege of taking care of, and this is the Stack family. Their son Landon was one of my patients and is now well into his Cleft journey with us and has already undergone his lip and his palate repair and is growing into a beautiful young man. And I think the Stack family is going to be able to speak to us about some of the key aspects of their journey and what that meant to them. So I thank you so much for your attention. I look forward to answering any questions you have, and I thank you for participating in this event with MyFace.
Good evening, everybody. We're very happy to be able to be a part of this evening's presentation and to share our experiences with everybody, because, you know, the two of us, both of us being teachers, we believe the more that we are vocal about our experience, the more that we can then assist others to understand, you know, what this process entails and what having a good plan and organization can really do to, you know, quite frankly, ease the pain at different moments and keep you more aware of just how to get this done properly.
Yeah, I agree. The difference, or what I think made it more difficult when we got the diagnosis for Landon, was that I myself was born with a cleft lip, and knowing the pain that goes with growing up and, you know, maybe looking different, you know, there are self-esteem issues. The last thing you want is for your child to feel any kind of emotional pain or physical pain. And that came to the forefront when we were in the room for the ultrasound. We have two older children that are 11 and 9, both of which do not have any cleft lip or palate issues. So I really believe that when we were pregnant with Landon and we went for that ultrasound, it wasn't even in our minds anymore that it could happen, because our older two were fine. And I'm sure anybody in that situation knows that when that room goes silent, you know there's something wrong. And that room went very silent very quickly. And what made it harder was that it really didn't help prepare us for the news we were about to receive. And out of nowhere, you know, kind of a doctor came in, and then we were moved into another room. And to Dr. I's point, this notion of needing a support system in place for parents when they receive that news is so critical.
I think, you know, you're in that room, and there's so many emotions swirling around you. And, you know, it was at that moment, you know, we're in this new reality. All of a sudden, you know, we're getting ready to celebrate this new baby. And all of a sudden, you know, conversations about how much time we have left for termination in the state of New Jersey, you know, are brought into the conversation. And you know, you walk into this room and you think you're having, you know, your baby, and then the word termination is brought up. You know, it's like a freight train. Mm-hmm. And, you know, we were lucky in that moment that somebody in the room did also say, and I don't remember who said it, said Columbia, you know, that this is one of the places to check. And this is the beginning of us trying to form a plan. But the problem is that when you get this information, you feel so completely isolated. I think that was something.
And it's not something people talk about. I know when we met Dr. I, and it was the second doctor that we had met. And I remember Dr. I going through those photos, and honestly, seeing those photos was such a gift, because it helps you to see what you will have on the other side of what is a difficult journey in the beginning. There's learning how to feed your baby and make sure your baby gains weight, because you want to make sure your baby has the surgery. And making sure that your heart can rest for a minute, knowing that there's an end. And we do look at our baby who's just over 2 now, and all you see is Landon. There's no cleft to see, and he breathes life into every day. And we're now on the other side wanting to help families on their journey too. What I do wish, and what I am so appreciative to my face for and to Dr. I for, is their desire to broaden a community that can help people. It was to Jonathan's point, a very isolating last 6 months of my pregnancy. I didn't want to talk about being pregnant. I didn't want to talk about the realities that were in front of me. I kept everything very much inside, which, had I had more people to communicate with, I think would have made that journey much, much easier for me, being pregnant and enjoying it, and not focusing on the stress that was waiting for me from the moment I gave birth.
And I think that's what it is. It's overwhelming. And, when we began the process of researching, we had looked at a facility here in New Jersey. We had planned to go to CHOP, Children's Hospital in Philadelphia. And, we sat down with Dr. I, and, again, to talk a lot of, it's interesting, a lot of what Dr. I, talks about during this presentation. We have flashbacks again to the photos, like my wife had mentioned, to that full diagnostic day, which, for me as the husband, it's one thing. For my wife to go through that diagnostic day, it's a daunting task. But, at the end of the day, each step you start to find things to be more manageable. That's the shocking reality of this, is that you can't look online. If you look online and you start looking at the pictures online and you start trying to go down that rabbit hole, it becomes all the more frightening. And you need somebody with a knowledge base to guide you through this process. And one of the things, both Adrian and I, we are very process-oriented people. I need to know what the next step is, because if I can't look 100 steps down because it's overwhelming. But if I can look one step down the road, I can process it. And that was really what assisted. That's what helped me and Adrian go through this process. Dr. I mentioned the pre-surgical work. One of the most important things I have ever done or will ever do in my life was listening to Dr. I's instructions about how to use that pre-surgical work to tape my son's face together in the morning, to put the hooks in his nose, to give that lift, to give, what Dr. I was saying, even that extra millimeter of work or whatever he needs to perform that surgery. That's what I did every day. And it became part of my process, my daily process. And the more that I could be engrossed in that, it helped me be able to support the baby and support my wife through this whole process of just taking Landon to that surgery. Because when we get to those surgery days, they're profoundly difficult days. But if you have these steps and you have the right team in place to support you, that offers you just a plan. And that's all I think that you're looking for, is a plan. Now, Adrian, you spoke to other people too, so you know a little bit better about that than I do.
Yeah, so I would recommend to anyone that's listening out there to throw caution to the wind and to reach out and find someone that is a little further ahead of you in this journey than you are, because what it will offer you will pay off in dividends. I had the beautiful opportunity to connect with a woman whose daughter was also a patient of Dr. I's, and she answered every one of my texts. She answered every one of my concerns. She checked in on me the day of my son's surgery. To have someone that has walked in those shoes before will offer you something so unique and so profoundly beautiful that no doctor can offer, no other person can offer, because they're in that emotional place just like you are. And that's what we hope to be for families, to be a bridge between where you are and where you're going to get to. Because without that bridge, it's such a insurmountable journey at times, where you feel like you'll never get it, but you will. And the day is a beautiful day where you can breathe and the support has paid off. So take the help. I'm definitely telling you to do that.
Thank you, Adrian and Jonathan. I want to ask a couple of questions, if I may, directly to you before we get into the Q&A with our audience. So you said get the help while you're in the prenatal stage. You're now a couple of years into this. Can you talk a little bit about that help now that Landon is born, has gone through his surgeries? What's that community like for you now? And why is that important to you?
I think as a mother being pregnant, just to help calm your nerves. Because when we were initially told about the cleft, we were also told about a multitude of other elements that could have been wrong with Landon that didn't end up being issues. But to have a support system and a lifeline, I think is great for the mental health of the mother. I'm speaking from experience for that. The mental health of the father in order to support you when you're pregnant. And if you do have other children, it's so important for them too. We have 2 older children that, as I said before, 11 and 9, that have gone on this journey with us. And even when I was pregnant, they knew about Landon's surgeries that would be on the horizon. So it's important for them also to have a support system in place where their care and their emotional needs can also be met so that you're all moving forward together.
Thank you. Let me ask a follow-up on that. You talked about not talking about the pregnancy while you were pregnant. What are your thoughts? What guidance do you have to share about that? When is the right time to talk about that with people you know? And just elaborate on that a little bit more.
I think Stephanie, if I could do it again, I would open myself up more. I think I was very guarded and I wanted to keep my emotions, buried a little bit for my own protection. And I think for us as women, when we're pregnant, we're vulnerable because there's already hormones going on, but to ensure that you're caring for yourself enough, I believe reaching out for help is of the utmost importance. And we're going to have a guest star in a moment. Sorry. I'm sorry. But such is life, right?
The other thing that's bizarre in this, and I guess it's a human reaction, is that you have this odd feeling of shame. Like it's this bizarre, selfish reaction, and there is no shame in this. This is just it's a genetic anomaly. It's a cosmic crapshoot. It's bizarre to have that kind of reaction. And I'm talking solely from my perspective, that we were very quiet about all of this and we weren't discussing it. And it's a human reaction, but it's a bizarre, illogical reaction. And I guess it's easier again to say it now from this side, at least from my perspective.
Well, and I think to that point, for anyone out there that's dealing with this right now, I was born with a cleft, so I immediately blamed myself. And what path have I put my son on to experience anything that can hurt him? And it's not your fault. It just is. It
just is.
And when you have someone come into your life like Dr. I that saves your son and gives him the gift. Yes, say hi, doctor. And gives him the gift of life. You are forever indebted to him, and I'm not going to get emotional, but that he just open yourself up, because there are more people out there experiencing it, and it's an easier journey when you walk the road with somebody else. It really is.
Oh, Adrienne, thank you. And hi, Landon. We would like to actually open up this conversation to our audience. So I'm going to ask the operator to give some instructions to our audience. But before the operator does that, I would like to remind you that we do have many, many people on this call this evening. And so for everyone to benefit, we ask you to keep your questions general in nature. And Dr. I, Adrian, and Jonathan will try to give an answer that is also general in nature. So if I can turn it over to the operator, could you please give instructions to our participants to ask questions?
Thank you. Please type your question into the Q&A box that is located on the bottom left side of your computer screen. One moment, please, while we now poll for questions. Thank you.
Okay, thank you. So let's start with a question for Dr. I. How early can a baby have facial surgery to restore their facial cleft? My daughter has a facial cleft, and at 19 weeks, the doctor said the cleft was severe and can possibly involve her eye. Is there any way to know before she is born, will she have full use of her eyes?
So this gets to one of the things that I try to point out for families about prenatal diagnostics. The prenatal diagnostics helps us know what the anatomy is. It's very good for that. And so we should be able to answer questions like, where is the cleft? Is it unilateral? Is it bilateral? Is it a cleft that's only involving the lip? Is it a facial cleft? The prenatal diagnostics don't often give us great answers on severity. There are some things that we're going to need to wait and see until baby gets here. So some of those questions about function, such as if we have a facial cleft, is the eye going to be functional, are things that are going to be answered after birth. But the extent and the anatomy can be confirmed before birth, and we should endeavor to give those answers to parents. And I would just say, in general, we normally aim for repair of cleft lip and facial clefts around 3 months of age. There is a range. Some centers, such as mine, do offer early cleft lip repair as young as 4 to 6 weeks. But the standard of care is about 3 to 6 months.
Okay, thanks. And let me further to that, here's a question. My child was born with a cleft palate that wasn't diagnosed until after his birth. What questions should expectant parents in general ask to minimize surprises like this?
You know, that's a great question. It's certainly one that comes to mind for someone who has had that experience already, right? Like, I would tell every parent during their anatomy scan to just ask the sonographer, like, hey, is the palate intact? It's an easy enough question to ask. I know that for each one of the times that my kids were born, I was kind of like holding my breath a little bit, waiting to hear that information that the palate was intact. So I don't think it's an unreasonable thing to ask. It is part of the standard anatomy scan to look for cleft lip and cleft palate. And if we don't get a satisfactory answer from just the ultrasound, in this day and age, we have adjunct imaging modalities such as fetal MRI, which poses no risk to the mother or the child, that can help us answer those questions. So these are questions to answer prenatally, ideally by 24 weeks.
Okay, thank you. Here's a question for Adrian and Jonathan. What suggestions can you make for parents to cope with the anxiety they will feel following the diagnosis?
Ooh. For that one, I would say, 1, take a deep breath, and 2, start the process of beginning that search for a doctor.
And that is the day after we got the diagnosis is when I began my research. That's when I began making phone calls. That's when I began making appointments. If you sit on this anxiety, if you sit on this, quite frankly, pain, and don't move forward, you can't solve the problem. You have to tackle it front on. You have to find the right team, the right doctor. And that's what we did. We found Dr. I, we found his team. And again, it gave us the process. You're so overwhelmed with all of the other realities. You need to know, all right, here's the first step. Here's the next step. Dr. I was talking about, the type of bottles, things, again, as veteran parents that we wouldn't even have begun to think about. Those steps need to be put out in front of you. If those steps are put out in front of you, then you can take one hurdle on at a time.
And I think when you, Dr. I, you talked about that comprehensive day of testing, and it is a battery of tests all in one day, and it's a lot. It takes a lot out of you as a pregnant woman, but the calm that came with following those directions and taking Dr. I's advice and doing it all in one day is you leave with this very clear picture of where you are. And that allowed us to then plan accordingly, because with the ultrasound, with the MRI, the genetic testing, just by the end of the day, you knew where you were, and that eliminated a lot of gray area. And that's, I feel, so important when you are faced with a diagnosis you're not expecting.
Terrific, thank you. Question for you, Dr. I am concerned about the delivery of my child. Can I go to my local hospital, or do I have to give birth at the hospital where my craniofacial team is located? What are the factors that should be considered in deciding?
You know, that's a really excellent question. And in fact, I glossed over it a little bit in the presentation, because that's also one of the goals of the diagnostic workup. At the end of a diagnostic workup, what I want to be able to tell a family is, you know, it looks like your baby is falling into the category of an isolated cleft or not. You know, there is a subset of children who are going to have something that's a little bit more complicated than that. And that's part of why we meet not just with myself, but also with the maternal fetal medicine specialists who are our high-risk OBs, because we should endeavor to give you some direction on what's going to be the most prudent plan to consider for your birth plan. I would tell you that in our practice in New York, in general, if a child is otherwise healthy and we the only malformation we have is a cleft lip and or cleft palate, I am comfortable with them delivering at their local hospital, because most New York local hospitals are going to have resources like a speech and language pathologist who helps with feeding, a lactation consultant, access to a NICU if necessary, and access to pediatric intensivists if necessary. Now, that's a New York model. In other areas, that may not be the case. And so I think the best answer is going to be given by a combination of your craniofacial specialist and your high-risk OBs to say, hey, this is a pregnancy where we think a child is going to do fine being delivering close to home, and then come to the craniofacial team when ready, or in some instances not. And one very example that happens quite often are some children that have cleft palate also have micronathia. Well, micronathia in a baby, which is a small chin, can be associated with breathing problems. So those are children where we're going to, you know, recommend that delivery be done at our tertiary care center, because they may need specialized care from day one after birth. And if they don't receive that care and those resources at the appropriate time, it can affect the rest of their journey. So every child's situation is going to be a little bit different, but that is definitely a question that should be answered relatively soon as we're going through the counseling and we're securing our birth plan.
Thank you, Dr. I guess further to that, I would ask, there's a question that's come in that asks, after surgery, what does the care continuum look like?
Again, another great question. I didn't go into much of the totality of the Cleft timeline because we only have a certain amount of time to share with each other this evening. I think that there are different standard areas where children with clefts interact with a cleft and craniofacial team. You know, if, let's say, for instance, a child has a cleft lip and palate, we're going to need surgery for the lip. We're going to need surgery for the palate. Those are infancies. As we move into the toddler years, ages 2 to 4, a lot of our focus is going to be on speech and language acquisition. There may not be surgeries involved, but you may be interacting with your multidisciplinary cleft team more with their speech and language pathologist. And then as we get into school age, 5, 6, 7, 8, in the area of early mixed dentition, now we're talking a lot about dental development, teeth development, occlusal concerns. And so we may be dealing now at that point with our dental specialists. And so I think the best answer really is link up with your local Cleft and Crainofacial team. If you're struggling to find a local team that you connect with well, there are national resources available through ACPA, through MyFace. Connect with one of those national resources to find a Cleft team that can help outline for your specific child what the rest of the Cleft continuum and Cleft journey will look like.
Terrific. Thank you, Dr. I. We have time for one final question, and this is a perfect question for Adrian and Jonathan. I have 2 children who will need assistance in understanding the siblings' craniofacial differences. What advice do you have?
We made it a whole process. We took our older 2 to meet Dr. I. We had explained to them, that the baby, he was going to have these surgeries, and they were aware of what was coming. And, we brought them to see Dr. I. I'm like, this is the man that's going to save baby Landon. This is what he's going to do. And we talked a lot about, like, with my oldest son, especially, we're sitting in Dr. I's office, and I go, oh, look, you see all those diplomas up there? That's Dr. I did all his schoolwork. And, we made it, a little bit of a teachable moment. But we explained, we were very open with them. We were very open and honest. Our 2 older children are incredibly amazing caregivers to him. They're at times a little overprotective, where they won't let him fall. They won't let him get bumped around. And we're like, no, he's okay. He's a baby, but he's not made of glass. But we were honest. We gave the details. We told them what he was going to experience. We would let them know when the first surgery was upcoming, right? When the second surgery, we're going to be away. We're not going to be home. So we were honest every step of the way, making them aware of every detail almost.
And much like your baby will be resilient and recover from surgery, and it will be such a distant memory, your older children are so resilient too. And the strength that they can give you when you feel low will lift you up. And I would even say, I know I sat and watched the 9 months that make us. I think that's the name of it. I'm not plugging for Netflix, but I'm just telling you that's where it's on. But there is a segment there on cleft lips and palates. And it was a beautiful thing to watch with my children so that they could see what's happened, what happens. And you see the children that they highlighted in that, how they come out of it on the other side too. And I think the more you are open with your children, the more they grow and develop and become stronger and more resilient people.
And Stephanie, I would just add that, part of my task in getting parents and couples ready for the birth of their child that's going to have a cleft is educating them, clearing up misconceptions, and then guiding them to other resources that they could then further educate themselves. And I think the same needs to happen for siblings and other extended family members who are interested, albeit maybe in a slightly indirect way. We all recognize that when we're treating a child that has a cleft, we're not only treating that individual, we are treating the entire family unit. The whole family is coming up on this journey. We're all getting in the RV. And so it's important for everyone to know what the road ahead looks like, and for older siblings, for them to understand as much about it as we think they can comfortably digest. And sometimes that's a little bit at a time, like, baby's going to be born with the boo-boo, but don't worry, the boo-boo's going to be fixed. And then we go from there about, how the boo-boo does get fixed. I invite parents to bring children into the office. And so I think communication and providing information and education are really helpful for everybody.
Well, thank you, Dr. I, Jonathan, Adrian, and Landon for being here. I mean, just incredible conversation. We're so grateful for you sharing your wisdom and knowledge with our families at MyFace. I do want to apologize that we're unable to get to all of the wonderful questions that were asked of us, But if you have additional questions, you can send them to info@myface.org, and we will certainly get back to you. And we will also answer the questions that came in that we were unable to answer tonight. Because craniofacial differences can truly impact the body and the spirit so significantly, MyFace provides important direct services such as access to patient and family support groups, all now virtual, topic-driven workshops, and online programs like this one that serve to educate as well as entertain. These programs offer guidance, resources, and a supportive environment for all who participate. MyFace also hosts unique networking opportunities that seek to bring our communities together, just like Dr. I spoke about and Adrian and Jonathan spoke about. We want you to know that you are not alone and there is a community that you can be a part of. And for more information about our programs and services, we invite you to visit us at myface.org. I also want to emphasize to everyone who's joined us today that we do really appreciate your feedback and comments, and we want to make sure that you complete the program evaluation form. We hope you enjoyed this program. Look out for an email to register for our next program in the Transforming Lives webinar series about psychosocial care and other topics such as navigating the financial and insurance landscape. Thank you for sharing your time with us this evening, and have a wonderful night.